Okay, so we're on page 91 in the lab packet looking at the urinary system. We also call the urinary system the renal system and urinalysis. So the first part has you just identify the major parts of the kidney using a model, a diagram, or a microscope slide. So if we go to our PowerPoint here, looking at major parts of the kidney, the cortex is the lighter outer portion of the kidney. So all of this outer portion, we call that the cortex. And then the medulla is the darker inner portion. So you see these little areas, these pyramids we call them, the darker portion, that's the medulla. So I try to think of medulla as more middle, and then cortex is on the outside, kind of like the cork on a tree. You know, it's that outer bark. So cortex and medulla, the lighter portion, darker portion. So, and we'll look at a couple of slides also toward the end of lab. So if we look at the blood supply serving the kidneys, the renal arteries deliver 25% of the total cardiac output. So they receive a good blood supply. It's very necessary that we pass blood through the kidneys because the kidneys filter out wastes and they're in control of our electrolyte balance. So it plays a really big role. And maybe if you've known someone who's passed away near the end of life, usually when they start to say that the kidneys are failing, then you know that death is imminent because we can't live very long with some of these electrolyte imbalances, and acidosis sets in, and that's what causes enzymes to not work anymore and leads to death. So people either go on dialysis, or if all the systems are shutting down and they're in hospice care, then the kidneys are usually what fail and lead to death. So looking at the major blood vessels then, objective number 2, we have, remember the abdominal aorta runs through the abdomen. It's a branch of the aorta that comes off of the heart. And then a branch off of the abdominal aorta is the renal artery. So that supplies fresh blood to the kidneys, but it does need to be filtered by the kidneys. So some of the electrolytes going into that renal artery are not, the components are not going to be the same as that leaving the renal vein. So enters in via the renal artery, and then the renal artery branches into segmental arteries. That's not in your list, but as it branches and then goes between or through the middle of these columns here that are between the pyramids of the medulla, we call these the interlobar arteries. So they run in between the pyramids of the medulla. And then they branch and go across the top of the wider portion of the pyramid. We call these the arcuate arteries and veins. So the blue is the vein, the red is the artery. And I kind of think of it as like they're making an arc. So it's a good way to remember that, arcuate vein. And interlobar is just between these renal pyramids. So this is the interlobar vein, interlobar artery, and then the arcuate vein and artery. And then we have these small branches coming off of the arcuate vein and artery, and these are the cortical radiate arteries and veins. So cortex, cortical refers to cortex. Radiate, just think that they radiate outward. So that's what those small vessels are. And then if we look kind of how the branching goes in terms of blood supply, so we have fresh blood leaving the heart through the aorta, like I said, enters the renal artery, then into the segmental artery, interlobar arcuate, cortical radiate. And then there's this exchange between artery and vein, which occurs in the glomerulus. So to understand this exchange here, where we go from oxygenated blood to deoxygenated, you have to understand the glomerulus. So we'll look at that next. So the glomerulus is this tuft of capillaries here. And it has an arteriole, which is a small artery, that enters into the glomerulus, and then there's an arteriole that leaves the glomerulus. So notice that they're both red. So this is the only capillary bed in the human body that has 2 arterioles, one on either side. Because if you remember from the cardiovascular lecture, we have an arteriole going on one side of a capillary bed, and what's on the other side? A venule, which is a tiny, tiny vein. So only the glomerulus is a tuft of capillaries with 2 arterioles. So we have the afferent arteriole leading into the capillary, And we have the efferent arteriole leading away from the capillary, from the glomerulus is specifically what we're calling the capillary here. So when we look at our diagram here then, so we have the afferent arteriole leading to the glomerulus, and then the efferent arteriole is what leaves the glomerulus, and then the blood enters into these peritubular capillaries and vasa recta, and I'll show you a diagram of that. But then we have blood entering into the venous circulation and then going back to the abdomen via the inferior vena cava, and if you remember from the cardiovascular system, that leads to the right atrium, and it all starts over again. Okay, so you'll have to know just blood supply given a diagram or a model. And looking at peritubular capillaries, I don't know if I have a specific diagram of peritubular capillaries. PowerPoint here. I don't see one, so I'm going to show you one online. All right, this is just a picture I took from online. So you can just type in peritubular capillaries vasa recta, and you'll see how this branches and becomes the venous portion. So the peritubular capillaries are just all these little capillaries that wrap around the nephron. And they're typically up in the cortex, because you'll see the division here, cortex medulla. So it's in the top half of the kidney where we find these upper portions of the nephron, and that's the peritubular capillaries. And then you'll see this special kind of net-like structure of the vasa recta. Again, part of the vascular system, and again, leading into the venous portion of the vascular supply to the kidney. So this is the vasa recta down low in the medulla, and the peritubular capillaries wrapping around the upper portion of the nephron out in the cortex. So we don't really have a model that shows that, so expect to see that in a diagram. So these nephrons then are the structural and functional units of the kidney. There's 1 million of them, about 1 million per kidney, so quite a few of these. So if we have damage to some, we've got plenty more to replace it and pick up the function. So the two parts that begin the nephron is what we call the renal corpuscle, and it's made up of the glomerulus, which is actually part of the vascular system. It's a tuft of capillaries. And then it has this Bowman's capsule wrapping around the outside of it. So if you see this yellow, this cup-like structure here, that's Bowman's capsule. And then the glomerulus is inside of it. So we call these two structures together the renal corpuscle. So together it makes up that. And in terms of understanding the cellular makeup of these parts, we know that the glomerulus is made up of simple squamous epithelium because it's a capillary. And all capillaries are simple squamous epithelium because they allow for rapid exchange. And Bowman's capsule, same thing, simple squamous epithelium forming the walls of Bowman's capsule. So if we get down beyond that then, we get into these proximal and distal convoluted tubular cells. Then the cell structure changes a little bit, and it's simple cuboidal epithelium. So these are more square-looking cells. So we call those simple cuboidal. So going back to our picture here, so this portion is all simple squamous epithelium. And then this is the proximal convoluted tubule that's right close to Bowman's capsule. And then this is the distal convoluted tubule. Both are in the cortex, and they're both made of simple cuboidal epithelium. And these cells undergo an exchange with the peritubular capillaries. The peritubular capillaries have been removed in this picture, so you can't see them, but that's where the exchange is occurring between the kidney, which is the nephron, this yellow structure, and then the blood, which are those peritubular capillaries. And then down here, the loop of Henle is exchanging contents with the blood through the vasa recta. Remember that net-like structure that was wrapped around the loop of Henle. So you don't have to know here the specific cell types of the loop of Henle, but you do need to recognize the loop of Henle and some of these other structures on a microscope slide, and we'll look at that in just a minute. So the renal tubules are the loop of Henle. There's an ascending and descending limb. You don't have to know the tissue types. They're not listed in your objectives because it only says if they're listed. So the only listed cell types are in objective number 3 are A, B, and C. The other, and D, the collecting duct. So they're all simple cuboidal epithelium except for the glomerulus. And then you can see the thin segment of the descending limb of Henle is also simple squamous. But you don't have to know that. It's not listed in your lab objectives. So when in doubt, simple cuboidal. So there's the thin segment of the loop of Henle, simple squamous. And then the distal convoluted tubule, like I said, cuboidal cells. So I'm just going to show those square, more uniformly shaped cells. And then the collecting duct is at the end of the nephron, and that too is simple cuboidal. So here, this is from your textbook, kind of summarizes all the cell types here and labels all the different portions of the nephron. So make sure you know what these different portions of the nephron are called. The collecting duct is not part of the nephron because it collects urine or filtrate that has been formed in each nephron. So you can see there's several connecting points for different nephrons to hook up. So the end of the nephron is with the distal convoluted tubule. That's where it ends. And then the collecting duct begins, which is not part of the nephron. So here's a slide showing some of these structures. If I look at this slide here, I can see the glomerulus is in the center. You can see the dark cells inside that have picked up the stain. And then you see the white, which is the space between the glomerulus and Bowman's capsule. So Bowman's capsule are these cells out here forming this outer edge of that capsule. And the space is just where the fluid would be held, right? So if you have blood inside of this glomerulus under pressure, hydrostatic pressure, right? Capillary hydrostatic pressure, which is influenced by our blood pressure. So the higher the blood pressure, the more push of blood out of this glomerulus into this space here of Bowman's capsule. And then that fluid will drain from Bowman's capsule into the first part of the nephron, which would be the proximal convoluted tubule. So if we look, now you don't have to identify what specific tubules you're looking at here, because if you look at, for a microscope slide, you just have to know loop of Henle. For that, you're just going to look for these long, thin structures. The proximal and distal convoluted tubule, if you look at those in cross-section, you can see that there's those thick cuboidal cells. So this is in cross-section, so each of these are tubular cells. Here we can see that as well, and it's right next to the glomerulus. Here you can see a glomerulus. Here's Bowman's capsule, the white space around it. And these are distal convoluted, but it's really hard to tell which is distal, which is proximal. So you pretty much just have to know that it's tubular cells. And then again, if it has very thin cells forming the outer edge, that might be the thin loop of Henle. But if you can identify just these tubular cells, that's good enough. Be able to identify glomerulus, Bowman's capsule, and the tubular cells, proximal or distal, doesn't matter. You don't have to distinguish between them. Same thing with the loop of Henle. But if you were looking for the loop of Henle, you would look for these, like I said, the thin wall of the thin loop of Henle. That would kind of give you a little hint that that was the loop of Henle versus, you know, across a longer section, say, of a proximal or distal convoluted tubule. This particular slide doesn't show that, but you would see the wider, you know, more uniform cells lining that wall. So as far as knowing the tissue slides of the vasa recta, you don't have to know that, but that's what this is showing. But here's, again, loop of Henle, these long segments here. And here's a collecting duct, and I know it's a collecting duct because, again, look at the wall. Simple cuboidal cells, look at the size of it, very large space, because we know the collecting duct is the biggest portion of this coming off of the nephron. So then that leads us into urine, looking at what we know about normal urine. It's slightly acidic. And if we let it sit out, it turns into ammonia. So that's what smells over time, right? When a child tinkles their diaper, it doesn't smell at first, but as that diaper sits for a while, then it has a very strong ammonia smell. And that's why people, when they put their diapers into a diaper pail, they usually keep that somewhere out of the main living space, right? Because it really gets strong. And same thing with pets, right? When a pet urinates in the carpet, it doesn't take long before you'll smell it and recognize, the dog's got a problem. So that ammonia smell is what you're smelling, but it takes a while for that conversion to happen. And also when people are on certain antibiotics, we know that that gives the urine a specific odor, and it can be very strong. We've had patients that have discharged, and the housekeeping will come through and totally clean the room, and the room will still smell like the antibiotic-laced urine from the previous patient. So it's very strong. And we know that asparagus causes a unique odor to the urine just because of the metabolites that are, the result of the breakdown of those, whatever compounds are in those medicines or food. So it should be pale yellow, very pale yellow. If it's dark yellow, we know that it's concentrated, right? There's not as much water. And the lighter it is, the more water is present in the urine. So if it's completely clear, then we know the person is really well hydrated and maybe, overhydrated, depending on the situation. If we're giving somebody IV fluids and they're producing a lot of urine, that necessarily isn't a good thing either, because that can be challenging to the kidneys. So that's one thing that does happen sometimes, I see in the hospital, is doctors will order fluids when someone comes in ill through the ER, and they'll order it at a pretty high drip rate, like maybe 100 mils per hour or more. And then they get better, and they're eating and drinking, and things are going well, and they forget to cancel the fluids. And that's a responsibility of the nurse, because the doctor's only there for a little bit each day. The nurse is there at the bedside, and she needs to be, or he needs to be monitoring the fluid balance of the patients. And I can't tell you how many times I've looked in the chart for the little bar graph showing how much is going in versus how much is going out. And we see huge imbalances one way or another. Obviously, if there's too much going in and not enough coming out, they're going to puff up and have edema, right? Or vice versa. If we don't have enough going in, they're going to be dry and have really low urine output. So we need to watch those things, because that can get missed when doctors are just looking at notes in the chart and looking at labs. So it should be clear pale. The pigment that gives urine its color is called urochrome. And we might see drug metabolites, vitamin supplements. We know that vitamin C, any excesses that our body doesn't use, is passed out through the urine. So people that buy high doses of vitamin C, they're just literally peeing that away. And we know that certain things in the diet can color the urine. Like if you have a lot of beta carotene, that can make the urine darker in color. And if you have cloudy urine, that's an indication that there's cells present in the urine, because urine should only be filtrated. It should only be water with dissolved solutes. We shouldn't see whole cells or pieces of cells in the urine, or precipitated molecules or compounds should not be present in the urine. So it's really important that people that are working with patients, maybe a person that's not even a nurse yet, if it's, say you're a nurse's aide or just a caretaker, a patient caretaker doing home health, and if you see cloudy urine, that's again something that the doctors aren't going to witness, and nurses may not even witness if if that task of taking that patient to the bathroom is delegated to the nurse's aide. They're the ones that can catch a urinary tract infection. So it's really important that they're looking at the urine, not just sitting them down, having them go flush it without any luck. Because there was a time when I was in nursing school that we were actually discharging a patient. She had her clothes on, she was ready to go, she had to go to the bathroom, and she went in the potty hat, and I noticed that it was cloudy and had an odor to it. And that's classic for a UTI. And she was going back to the nursing home. Well, the nursing home will ship them right back if they have a UTI, but sometimes it gets to the point where it's in their blood, and then it causes brain inflammation, and they act like they have Alzheimer's from it. So we want to catch that right away. So sure enough, we tested the urine, came back positive, put her back in a gown, back in bed, and she was staying for a while until we got the urinary tract infection under control. So that was just a perfect example of just, keeping your eyes open and paying attention to the minor details of patient care, which is looking at the urine, looking at the bowel record. When did they last move their bowels? Because you can, really save them a lot of pain and heartache by catching those things early. So again, the pH is slightly acidic, and that prevents infection. By having slightly acidic urine, that prevents infection in the urinary tract. So when urine starts to go alkaline, which is greater than 7, that sets up an environment for bacteria to grow. Because most bacteria, most common human infectious bacteria don't like acidic conditions. So if the urine pH changes, then that promotes bacterial growth. So some things that can cause an imbalance, if we have prolonged vomiting, we actually lose excess hydrogen ion because there's a lot of hydrogen ion that is produced in the digestive juices, hydrochloric acid. If we lose that through vomiting, that causes an imbalance, and that's going to bring pH up and cause us to go alkaline, which again is going to change the pH. So specific gravity is a value we assign to urine, and it's a number that does not have any units because it's a ratio that we compare the density of the urine compared to the density of water. And what is the density of water? Those of you that were not in high school too long ago, or that were in high school not too long ago, that's what I meant. What? Yeah, 1.00 grams per milliliter, which means that 1 milliliter of water weighs or has a mass of 1 gram. So if anything is higher than that, it's more dense, which means there's more stuff in it, right? So water doesn't have any solutes in it. Water is pure water, so it has a specific gravity of 1. So if urine has a specific gravity of 1.001 to 1.035, we know there's extra stuff dissolved in that urine that's making it a little higher in terms of its density compared to water. So the more concentrated it is, obviously the more specific, the higher the specific gravity is going to be, right? So looking at what's actually in urine, most of it is water. So most of urine is water, and then 5% are solutes, which are just dissolved things. And some of those are waste products, urea, uric acid, and creatinine. Where does urea, uric acid come from? Do you know? Where do we get that from? They're nitrogen-containing compounds, so what compound contains nitrogen? Those of you that know your chemistry again. What organic compound that we take in through our diet contains nitrogen? Amino acids, yeah, so proteins. Proteins in the diet are a source of that uric acid or urea. Where does creatinine come from? Yeah, creatine phosphate in our muscles, right? Part of that metabolism occurring in muscles. So those are waste products. They should be there. When we look at our urine samples, we're going to expect to see urea, uric acid, creatinine. Sodium and potassium, we don't have any deficiency of sodium in the American diet, correct? Would you agree with that? Any trip through a local fast food joint, you're going to get your fill of sodium for the day. Potassium, too, is in a lot of popular foods that we eat. But some people can be low in potassium in their blood, and we'll see a lot of it in the urine if they're on a diuretic, like Lasix or furosemide. That it kicks the kidneys in, causing them to make more urine to keep blood pressure under control, because if we can pee out excess fluid, that keeps our blood pressure lower. But it also causes the kidneys to dump excess potassium and not reabsorb it back into the blood. So people on diuretics are at risk for potassium imbalances, low potassium. So sometimes we tell them, if you're on this medicine, have some extra bananas, or potatoes are high in potassium. Other solutes, phosphates, sulfates, are also normal constituents of urine. Calcium, magnesium, bicarbonate ion, those are all normal ions we bring in through our diet. Excesses enter the urine. But if you have high concentrations, then something's going wrong, and we need to assess why that's happening. Structurally, what leads from the kidneys to the bladder where the urine is stored are the ureters. So ureters are lined with smooth muscle. They undergo peristalsis to move urine from the kidneys to the bladder. And when we say retroperitoneal, it means it's behind the peritoneum. So you have the peritoneal cavity that contains the digestive organs, and behind that, in their own membrane, are the kidneys. So they're kind of glued to the back wall of our abdominal region, and they're surrounded by their own membrane back there. As bladder pressure increases, the far ends of the ureters close, so we don't have backflow of urine into the kidneys. But again, if you had a person that wasn't able to go, say a person with an enlarged prostate or a neurogenic bladder that didn't empty on its own, then you can have urine back up into the kidneys, and that can cause increased pressure and do damage, permanent kidney damage. So we really have to make sure the urine flow is working. And if we have any doubt in that, and here's a perfect example, you have an elderly patient who says, I gotta go, I really gotta go. It's an emergency, and you rush to the bathroom, he uses the, sits down or he uses the urinal on the side of the bed, and he goes 100 mils. And you say, what, all that work for 100 mils? And then you put him back to bed, and then 45 minutes later, hour later, gotta go again, 100 mils. What should you be thinking? Is that normal? Think of when you've had to go, 100 mils? That's like less than a soda can. So what's up there, do you think? The enlarged prostate is possible. He's got a very full bladder, right? So it's stretching, saying, gotta go. But he can only tap off 100 mils. So what happens then? A little more urine fills and it's full again. So is he emptying his bladder every time he goes? No, and that's why he keeps getting full and giving that urgency. So what should we do then for those of you that work in healthcare? What should you do when you're going to the potty hat every hour for only a little bit of urine? Well, before that, a bladder scan. Yeah, it's an ultrasound thing, real easy. They have them on, the floor. It's just you squirt a little gel, just like if you've ever had a baby, squirt a little gel and you put the wand over where the bladder would be, and it'll tell you how much urine is still in the bladder. And if it's greater than about 300, then we think, okay, we've got to do something here, because that's too much to be sitting in the bladder after having just gone. And I'll tell you, that's another thing that gets overlooked, is people just keep going to the bathroom. They're not thinking of their anatomy and physiology, and they're just taking the patient to the bathroom every hour for 100 mils. That's a sign that something's up and we need to explore a little more. Okay, so as far as the ureter, there's not much more you need to know as far as details on the ureter. We'll talk more about that in the lecture, but just know that, peristalsis carries that urine from the kidney to the bladder. So here's the outer lining of the, let's see, we are at, this is just the layer of the ureter. You don't have to know that, I don't think, for the lab exam. And I'm looking, do you see anything about a slide of the ureters? I think that might just be extra. Yeah, okay, so we'll skip that. Renal calculi are just kidney stones. It's a fancy name for kidney stones. So calculus is from crystallized calcium. So calcium phosphate is a common molecule or compound that forms kidney stones. And some people are just prone to them, and they're extremely painful when they're passing through the ureters out of the kidney. Sometimes they can break them up with ultrasound to decrease the size, but oftentimes they're small enough to just pass on their own, and it's extremely painful. They call it, when it happens in men, they call it the male version of childbirth, because except you don't get a reward or a prize at the end, you just get a stone in the bottom of the toilet. Or women get a baby, so not fair, but the pain is pretty severe. So a couple of different reasons that could cause it. They form in alkaline pH. So again, some of the things that cause the pH to go alkaline that we mentioned on a previous slide, like prolonged vomiting, dehydration, that can lead to kidney stones, play a role. A lot of excess calcium in the blood can cause that. Sometimes people have tumors on the parathyroid, which controls calcium balance, and that can lead to kidney stones. Urinary retention, again, so someone with increased prostate enlargement can have problems with kidney stones. So keeping that urine flowing is really important for kidney health. Oops. So looking at your lab objectives, I want to just talk about a couple more things here. So we would expect to see, like in objective number 7 talks about, we would expect to see in urine those substances, and I don't want to forget about hormones, because we talked about with the endocrine system, any excess hormone that we have that's not binding to receptors and actively being used is just going to be excreted through the urine. So that's where we'll see excess hormones. And then we'll look at abnormal parts of the urine and what that means. So there's a condition that we call, if there's sugar in the urine, if we see glucose in the urine, That's called glycosuria. Glyco always refers to sugar. So glycosuria. And whenever you see urea at the end, we're talking about the urine. If ever you see emia at the end, we know we're talking about what? Blood. So all of these are going to end with the word, the suffix urea. So glycosuria. What would be a condition? Diabetes, right? If you have sugar in the urine. Or extreme stress, like if someone ran a marathon, they might have sugar in their urine because the extreme stress of that event. Protein in the urine is called, proteinuria. And if it's albumin, that specific protein, then it would be, take a guess. Yeah, albuminuria. Wow, that's a hard one to say. Ketones, ketonuria. And when would someone have ketones in their urine? Do you remember when ketones are produced? Where we see excess ketones? Yeah, extreme weight loss. So people that are malnourished, people that are on the Atkins diet, when there's no carbs, there's not enough carbs to be used as fuel, the body burns muscle, and ketones are produced as a result of that. Erythrocytes, which are red blood cells, so that would be blood in the urine. So we call that hematuria. Hematuria. And white blood cells, which is pus, so we call that pyuria. What would cause hematuria? Blood in the urine. A UTI for sure. Menstrual cycle. So it's not actually blood in the urine, it's just mixing with the urine, right? Because it's coming out from the same proximity. Another one would be if the glomerulus gets damaged and the holes of the glomerulus get bigger because there's tiny little spaces, for things to come out of the glomerulus, not red or white blood cells, but if for some reason they have damage to the glomerulus, like glomerulonephritis, which causes an inflammation of the glomerulus, red blood cells can sneak out, and now you've got blood in the urine. Anytime you have damage to the urinary tract, someone just had a catheter pulled out the day before, and they're going to the bathroom and people see blood in the urine, oh my gosh, terrible. No, normal, right? If you're pulling a catheter out, there may have been some trauma to the urinary tract. That can happen. Crystalluria, and that would be if you have crystallized urine, something is, precipitating out. There's two different types of solids we might see, and this is on the top of page 94. I would highlight these two terms. We have casts and crystals. So precipitated minerals are the crystals, like uric acid can crystallize, and then it settles down in the interstitial fluid and ends up in the lowest part of the body, the joint of the lowest joint in the body, which is the big toe. Have you heard of what's the condition that people get a big swollen and inflamed and sore big toe because of uric acid crystallizing? Gout, yeah, very painful. It's common in older men, but women can get it too. And sometimes they give them a medicine they take every day just to prevent that crystallization of the uric acid. But anyway, so that's what crystals are. And then casts are these kind of uniquely shaped. They have a real nice orderly shape. They're cylindrical. And they form when things are not moving through. So they kind of sit in the nephron too long. And they have these cylindrical structure. And then they end up in the urine. And sometimes they're made up of cells, or they might just be made up of, having a molecular basis, not made up of cells. So if you read, if they're cellular, it tells us that there's problems in the kidney. There's damage within the kidney itself versus the lower urinary tract. but you don't have to know, you don't have to diagnose what casts are. Just know that casts are those cylindrical structures and crystals are just mineral precipitates that we might see in the urine. Okay, so going back to the different conditions. So if we have hemoglobin, that's the same thing that we would see with red blood cells in the urine. What would we call that? Hematuria. If we see hemoglobin or erythrocytes, because hemoglobin is what gives erythrocytes their red color, so that's hemoglobin, hematuria. And then bilirubin would just be bilirubinuria. And bilirubin is a byproduct from the breakdown of red blood cells. So we would expect to see bilirubin in the urine. It also gives it that yellowish color as well. And it's broken down in the presence of sunlight. So if a person has a urine sample, they don't want to set it on a sunny window in the clinic lab. You want to keep it, away from the sunlight because that'll break down the bilirubin. But we should see some amount of that in there because it's a normal byproduct of red blood cell breakdown. So looking at some other terms related to the urine or urination, urochrome, what did we say that was? The pigment that gives urine its yellow color. Turbid, what does the word turbid mean? Cloudy. It's another word for cloudy. What would cause cloudy urine? Yeah, infection, urinary tract infection. Polyuria means a larger than normal volume of urine is produced over a certain period. So we call that polyuria. Oliguria means less than the normal amount of urine is produced. So there's a smaller volume of urine being produced. And this is typically important when people are coming out of surgery. We try to make sure they're putting out at least 300 mils an hour after surgery to show that the kidneys are functioning again. And if we see less than that, then we'll go in and examine, find out why that might be, maybe give them more fluids. But some people, especially the older people, their kidneys take a little bit of a hit with major surgeries like bypass surgeries and things like that, abdominal surgeries, that it might take a little bit for those kidneys to start working again. So we call that oliguria if the volume isn't quite where it should be. And anuria would be there's no urine produced. And that's one thing I had to get used to when I became a CNA and just first entered the healthcare environment, is they would tell me in report, yeah, this person's on dialysis, kidneys are absolutely non-functional. Okay, sounds good. And then I go in their room, did you pee today? No, I only pee on Monday, Wednesday, and Friday. Oh, and it's through the dialysis machine, so I don't pee. So if they're on dialysis, some do produce a little bit of urine, but many do not produce any urine. That's, their kidneys don't work, so they have a dialysis machine that filters the blood for them. So there's no urine production. So we call that anuria. Proteinuria, we talked about albuminuria. These are signs of, in pregnancy, it's called, oh my gosh, I'm having brain lapse now. What is it called? I'm sure did you have it? you had the difficult pregnancy, didn't you? What is it called? Thank you, preeclampsia. And that can lead to eclampsia, which is a very serious condition that can cost the life of the mother and the infant. So symptoms of preeclampsia that they look for is protein in the urine, high blood pressure are two key findings that they're going to look for. And sometimes they'll take the baby early because of, that preeclampsia that they can't control. Anybody know someone who had it or did have it? You had it? Oh, you know someone? Really? Yeah. Did the baby turn out okay? And oh, that's good. That's good. Yeah, it's a pretty serious thing. So that's why every woman who goes in for her pregnancy checkup throughout the pregnancy, they're always going to get a urine sample. They're looking for sugar in the urine, looking for gestational diabetes, and they're looking for protein in the urine as a sign of preeclampsia. And they're always going to look at the blood pressure as well. So I think that covers everything. We're ready to test urine. So we'll start. Okay, so this worksheet is reviewing last week's material on fluid balance. So percent of extracellular fluid, like what of all the fluid in our body, what percent is found outside of our cells? 37%, yep. And there's a special name for the CSF and synovial fluids. They're called transcellular fluids, correct. And what do we call the fluid inside cells? Intracellular fluid, correct. And that's letter B. The main force pushing water out of capillaries, we talked about this in lecture last week. Yep, it's letter C, blood hydrostatic pressure. And the major sources of body water intake. Beverages, obviously, right? What we drink and also what we eat in terms of food. So N and P, food and beverage. So if someone has really high blood pressure and a failing heart, we would want to put them on a fluid restriction, right? Because we want to decrease the amount of water that's in their system. So we'll put them on a diuretic and we'll say you're only allowed to drink 2 liters of fluid, food and beverage, each day. So I've seen it as low as 1.5 liters, but 2 liters is a common one. So the name of fluid inside the lymphatic vessels, this is pretty straightforward. Lymph, letter U. And the percent of fluid that's found inside cells, known as the intracellular fluid, letter D, yep, 63%. The main force that returns interstitial fluid to the blood. So it sucks fluid in. Yep, letter T, the blood colloid osmotic pressure. And what fluid compartment do we see a lot of sodium chloride and bicarbonate? Extracellular fluid. Yep, letter F. Main forces moving water in and out of cells. So we're talking about across the membrane. Yep, letter G, cell colloid osmotic pressure, and also interstitial fluid osmotic pressure. Yep, that would pull fluid out of cells, right? Depending where there is more solute, of course. Name of fluid between cells. We've known this all semester, hopefully. We talk about it a lot. H, interstitial fluid. And what is the hormone that causes us to hold on to water? Antidiuretic hormone, ADH, letter O. Major source of water output. How do we get rid of the excess fluid in our body? Urine. And you may notice if you've eaten a lot of salty foods, maybe you'll feel bloated the next day after that, and you might notice later that same day or maybe the next day that you have increased urination, even if though you're not drinking a lot. And that's the kidneys responding to that excess fluid in your system and kicking it in gear and urinating that excess away. And that's what healthy kidneys should do, is to keep your balance. But when people have failing kidneys, then they really have to, again, watch their salt and their water intake. Fluid compartment with increased potassium, phosphate, and protein. So these are things that are found inside cells, right? Potassium is an intracellular ion, so that would be letter B. It's found in the intracellular fluid. And then fluids with increased protein. Where do we see a lot of protein? The plasma. We have albumin, letter S, plasma. And also, where are proteins made? Inside cells, yeah, the intracellular fluid, letter B. So this is B and S. And then lesser water outputs. Where do we see some water leaving the body through smaller amounts? Perspiration and feces. And other sources of new body water. Think of the equation for cellular respiration. Glucose, right, is broken down with oxygen to form carbon dioxide, water, and ATP, right? So we produce water by breaking down sugar. So letter Q, water from metabolism, is another source of new body water. A hormone that reduces the reabsorption of sodium. which means it helps us bring down a high blood pressure. This is the only hormone, and you need to know this for the exam, it's the only hormone that reduces blood pressure. All the other hormones we talked about raise a falling blood pressure. Yep, atrial natriuretic hormone. Remember natremia? So NATR is referring to sodium. And letter F, I'm sorry, oh, I just gave you the answer. The general name of fluid outside cells is letter F, extracellular fluid. You knew that one anyway. All right, force that moves fluid into the lymphatic system. So the lymphatics are sitting out in the interstitial fluid, right? What pushes those valves open? Yeah, the hydrostatic pressure of the interstitial fluid, so letter J, pushes on those valves of the lymphatic and lets that fluid enter. Hormone stimulating sodium reabsorption and potassium secretion. Yep, aldosterone. And the name of the fluid that's in our circulatory system or inside of our vessels, what do we call that fluid? Plasma. I don't see it. Nope. Nope. All right, so then it says to draw arrows in the diagram to show the way the water is moving because of the forces represented. So we have blood capillary, so blood is entering into this tissue space here through this capillary. So fluid is entering here and water is going to move out on the arterial end. So you want to draw an arrow moving out. And then as pressure decreases across this capillary, that pulls fluid back in. So I want you to draw an arrow going into the capillary on the venule end. So fluid goes out at the arterial end, and then it comes back in on the venule end. Because remember when we looked at the lymphatic system as far as what you did online, right? That was an online thing. How much actually stays in the interstitial fluid and enters the lymphatics? How much per day, do you remember? Lymph fluid, up to 3 liters a day. Enters, leaves as lymph and is recirculated and put back into the general blood supply up near the heart. But most of it that leaves at the arterial end goes back in the blood at the venule end. Okay, so color coding, where is the ECF? We should color code that. If you have a marker, it might be helpful. But where is extracellular fluid? It means any fluid that's outside of cells, right? So is this extracellular fluid inside here? Yep. And how about here? Outside the cells. Extracellular fluid? Yes. And then intracellular fluid, or ICF, is inside the cells, right? Only here. So this would be ICF. So you'd color everything else extracellular, and the only intracellular is inside cells. So we shouldn't see a big net movement of water across cell membranes, should we? Because what would happen to the cells if we lost water? It would shrink, right? And that would be dehydration. That would be advanced dehydration. And if we saw them swell, that would be advanced fluid overload. And that's the last step. Our body kicks in with these homeostatic mechanisms to control fluid imbalances because we want to protect our cells. So there's lots of things associated with the blood vessels to make sure that when there's excess fluid, we get rid of it via the kidneys or we store it via the kidneys with the help of hormones, right? To keep the blood pressure where it should be at. Because if we get too high or too low and we don't, and that goes unchecked, we see a shrinking or swelling of cells, and that's going to impair brain function. You're going to see that in your patient when they're either fluid overloaded or dehydrated. And you're going to see non-responsiveness, right? They're going to act sedated, extra sleepy, and then you have to make sure you address that. Okay, so next page then. The osmolality. What is osmolality? If you look at the plasma, osmolality was a term that in last week's lab refers to the concentration of solutes in the plasma. So we should have a certain osmolality that's normal in the plasma. And I can tell you that that number is, actually it's after this week's lab. I was just looking at it earlier today. The plasma osmolality. Thank you. What page is that on? 285 to 300 is in the third small paragraph or third sentence, kind of out by itself. 285 to 300 milliosmoles per kilogram. You do need to know that for the lab exam, so be sure that you have that written down or highlighted at least. Hypochloremia, what's the ion we're talking about here? Chloride, and it's high or low? Low, because it's hypo, right? So low chloride, letter K. Hypernatremia, what's the ion? Sodium, and it is high or elevated, so that's letter J. Hyperkalemia, the ion is potassium, and it's high, so that's letter A, elevated potassium. Hypocalcemia, what's the ion? Calcium, and it's low because it's hypo, so letter M. And acidemia, what is that? What is the normal blood pH? That's another thing you should know. Maybe you should write it up here on the side. Yeah, 7.35 to 7.45. So which of these is acidemia? G, pH is 7.33. It's too low. And hypocapnia, do you remember what capnia refers to? What is it, Jacob? You're nodding your head. Yep, carbon dioxide. So we have decreased PCO2, letter F. So the next part of lab is to test your urine, and for online students, I'll post a urine sample results for them to analyze. But we'll just continue down here. Normal constituents of urine should be electrolytes. So you can just say electrolytes, which are all those ions, right, that are in excess. And then what were the waste products we said? Uric acid, urea, yep, creatinine, metabolites, hormones, yep, and uric acid. Those are normal. So when we take a blood test and we see a large amount of creatinine in the blood, what does that tell you? Kidneys. Yeah, kidneys aren't functioning. That's supposed to be in the urine, not building up in the blood, so the kidney function is low. All right, expected pH range for urine. What's the normal range for urine? That's typical, but the actual range, what is considered acceptable, 5 to 8.5 is what I have. Do you have something different in your lab? Oh, yeah, the textbook might be different than your lab book because there's different authors for that. So 5 to 8.5 is what your lab book says. And then specific gravity, these match the lab from the textbook, and that's 1.0. Oh, does it say that? 1.001, because 1.003 is what your lab book says. Okay, so that's a little different. Okay, yeah, so your textbook is a little different. 1.003 to 1.035 is what your lab book says. Okay, looking at the different conditions here, which one? Hematuria means, what would cause that? Blood in the urine, so yeah, either one, both of those, D and E. Pyuria. Yep, letter F. Ketonuria. Starvation or diabetes. And that's because there's no sugar entering the cells, so the cells start to break down muscle for energy, and that's why they have ketones building up. The sugar is stuck in the blood and can't enter the cells. Crystalluria. Yep, precipitated minerals. Albuminuria. Sometimes, yeah. But it's one of those, just like we saw with the hematuria, these things are too big to pass out of the blood, so if we see them, it may indicate glomerular damage when we see a lot of that. You see a little bit of protein in the urine, that's normal, some slips out, but for the most part, if we have damage to that capillary bed, we're going to see a lot more albumin. And glycosuria. Stress or diabetes. Yep, yep. And then the next page, less than 50 mils of urine in 24 hours is called, so that's really like not enough to even count. Yep, anuria. And then 50 to 400 is not enough, oliguria, and more than 2.5 liters a day is polyuria. So for this, you're just going to draw in those vessels. I'll just let you do that. You have the diagram in your textbook to do that, so we're not going to do that together. So if we look at urine with a pH of 6, is that urine acidic or basic? Acidic because it's less than 7, right? So the patient's blood is 7.4, and that's normal, right? So what would cause their urine to be so acidic then? What are the kidneys getting rid of to keep that urine, or to keep that blood pH where it needs to be? Yeah. So the kidneys are excreting excess hydrogen ion to keep the blood pH normal, but it's causing the urine to be slightly acidic, more acidic than it would normally be. And what other ion affects pH that if the kidneys hang on to this ion, the blood pH is raised? So we have hydrogen ion, and what was the other one, did we say? Yeah, bicarbonate ion. So if it reabsorbs or hangs on to bicarbonate ion, sends that back to the blood, then that's going to keep blood pH higher also and not dipping down into the acidic range. So the kidneys are excreting hydrogen ion and reabsorbing and sending bicarbonate ion back to the blood. So we have a specific gravity of 1.03. So is that high or low? That's high, right? That's on the high end of normal. So what does that tell us about the number of solutes in that urine? There's a lot more solutes in the urine. So what does that tell you about what's going on in the plasma? What are the kidneys trying to accomplish by having a concentrated urine? What? Well, think about what we need in our blood to maintain blood pressure. What? We need water, right? So if we have a concentrated urine, that means the kidneys are conserving water, not spilling it out into the urine, right? So that water that enters in through the vessels, through the renal artery and the branches of the renal artery that eventually lead to the nephron, the kidneys are sending that water back to the blood, and what leaves the nephron as urine is concentrated with less water. And then we have a patient considered urinalysis. He presents with vomiting and diarrhea, is dehydrated. His specific gravity is 1.01. Is anything wrong with this picture? So he's dehydrated, vomiting, and diarrhea. What should his specific gravity be based on what we just talked about? It should be higher, right? It should be higher, but is it? No. So are his kidneys functioning properly? No. They're supposed to be conserving water, right, and sending it back to the blood, and we should see this number to be very high. If a person is dehydrated with vomiting and diarrhea, we should see a concentrated urine. And that's what they'll ask, say, parents when they bring in a baby that's dehydrated. They'll say, when was the last time they had a wet diaper? Right? And they say, oh gosh, he hasn't peed all day, actually, right? Or when they cry, they have tearless, crying, and that's another sign of dehydration. If the kidneys are functioning normally, they should be conserving water. So this person has kidney damage, kidneys are not conserving water. So glycosuria and ketonuria can occur in diabetes insipidus is when there's a tumor on the pituitary gland, the posterior pituitary, causing causing a blocking of ADH, and as a result, they have excess urination. So diabetes insipidus has to do with excess urination. So that's not going to cause sugar and protein in the urine, but diabetes will, right? Because the body's starved, the cells are starved of sugar. It's all stuck in the blood but not in the cells, so they're breaking down muscle and fat. So that also mimics what happens in starvation. The body goes to eating muscle and fat, and eating the muscle as a protein produces keto acids. So we have sugar and protein. So we see that in diabetes and sometimes in starvation. What would you expect to be a finding? Oh, wait a minute, I'm sorry. Sugar in the urine we would not see with starvation because we're assuming a normal pancreas. We would see sugar and protein only with diabetes. We would see protein with just the starvation, or just protein with starvation. So diabetes only from number 12. And then blood in the urine, all of those, yep. And number 14, protein in the urine. Actually, it'd be all of them. Because we know our cells are made up of proteins, and when we damage cells, proteins spill out from inside the cells, and that can also lead to protein in the urine. But if it was only albumin, then would that change anything? It's only albumin in there. Where do we find albumin? In the plasma. So which one of these is causing plasma to spill out into the urine? Yeah, glomerular damage. And which is most consistent with cast formation? A low tubular flow rate. When the urine sits, it starts to form those cylindrical little structures. Okay, so that concludes this week's lab on urinalysis.